So moving right along to the different types of uveitis that one might see. When the uveitis specialist sees a child for the first time walk into the room, this is often what they'll see. An eye that looks quite like this. And then this is what goes through their mind, is what could possibly be the cause of what's going on. As you can see, it's quite a long list, and this isn't even a complete list, but several things to consider. And the uveitis specialist now has to go through a series of steps to try to figure out exactly what is going on in the child. As I mentioned before, the first thing that they consider is the anatomic location of the uveitis. Where is it? What part of the eye is it affecting? Oftentimes this helps to determine what type of uveitis the child has, which is important because that helps the treatment. Now, the story that the child and the parents tell about their uveitis is also incredibly important. It cannot be underestimated, the importance of just reviewing things that may not even be felt to be related to uveitis, but that's why the questions are asked as to different medical or parts of the medical background. Does the child have joint pain? Does the child have problems walking? Does the child have any problems going to the bathroom? This is sometimes information that can save the child's life. These are various questions that can be asked during the course of the exam. Like I said, many times the family that's visiting the uveitis specialist may not even think that they're related, but they can be, and oftentimes help to lead to the right diagnosis. And of course, testing, blood testing, imaging studies done, various things done targeted at what is suspected. Not always everything is done, but sometimes the wide net is casted. And should be directed and to try to find the right diagnosis, but these are all the different types of tests, including other things, which help to point us in the right direction. The types of childhood uveitis, based on anatomic location here, the majority of them are anterior, but they're also represented by intermediate, posterior, and panuveitis. The most common type of pediatric uveitis is actually idiopathic, meaning the etiology is actually not known. 3/4 of all kids have it in both eyes, and 2/3 of them have chronic or recurrent disease. The most common type of pediatric uveitis, anterior uveitis, is usually thought of in one of two types, either granulomatous or non-granulomatous, and that can help to determine, or more likely determine, what could be causing the disease, with JIA being lumped into the non-granulomatous category. JIA-associated anterior uveitis is the most common known etiology for pediatric uveitis in about 20 to 33% of all children. And as I said before, about 70 to 80% of these are female, have ANA positivity, and the oligoarticular form of the disease. Some blood testing can actually help in predicting the likelihood of the child to develop the type of disease. The HLA-DRB1 0405 allele actually is protective, or thought to be protective, as it is more commonly found in the polyarticular JIA population, which, as we know, less commonly gets uveitis. These are the different types of JIA as more recently defined in 2004. Oligoarticular is the most common type with fewer joints involved. This represents over half of the children with JIA. And the screening guidelines, most recently revised in 2006, notably the high-risk population, those kids without juvenile idiopathic arthritis or uveitis, who need to be seen on a regular basis to make sure they do not develop it, as the disease is often quiet and the children are not aware that they have the problem, nor are the adults. So the children are seen on a regular basis based on the risk stratification seen here. This is a picture of a child with JIA uveitis. As you can see, the white, quiet eye. However, several complications are present, and those are notable to the trained eye here. But they may not be immediately present to the parent or friends or family of the child with JIA uveitis. This patient actually had active disease and needed acute treatment with corticosteroid therapy and a change in systemic immunomodulatory therapy. Oftentimes the disease is bilateral and sometimes affects the area in the front and just behind the iris. Most oftentimes it's insidious, meaning that it's not known that it's there, and caught during regular routine vision screenings at schools, or just the parents taking the child to their eye doctor. Oftentimes, complications are already present because of this, and notably those are synechia, cataract, corneal changes, macular edema, hypotony, and 1 in 4 of these children are actually legally blind by the time they actually are diagnosed in this particular study. Important to recognize that ocular disease may often present prior to the formation of arthritis. So the other way around works too in kids with uveitis, where another etiology is not quite suspected or known. Pay attention to possibly developing systemic problems that they might have later on to help establish a diagnosis. Now, the HLA-B27 population typically presents quite differently. Oftentimes, these children have painful red eyes, blurring is quite prevalent. It can be in one or both eyes, and oftentimes, if it's in both eyes, it will affect one at a time. A very thick, fibrinous, almost soupy reaction in the anterior chamber is seen with or without a hypopyon, as is seen here in the picture. And oftentimes, they can have increased intracranial pressure because of the scarring down of the iris to the lens and prevention of fluid to be escaping from the normal channels in the eye. These are different systemic syndromes which can be present with the HLA-B27 type patients in uveitis. Most of them arthritis, most of them affecting younger or older boys. However, they can also involve psoriasis and inflammatory bowel disease. Important to note that they may not just have one of these, but they may have multiple types of these problems, so that's where the review system comes into handy, and multiple specialists oftentimes are working with these kids to help treat their disease. TINU, or the tubular interstitial nephritis and uveitis syndrome, is pretty rare, but can be something that can show up. It's usually in teenage girls, and thought to be triggered by infection or drug exposure, so a history of that is important. Oftentimes, they will present with signs of renal problems, fever, flank pain, joint pains, also including arthritis. Urinalysis testing shows signs of renal compromise, and a urine beta-2 microglobulin is often checked, which can be elevated as the distal tubules are affected in the nephropathy, not able to reabsorb these proteins, and that's why they're seen on testing. And of course, renal biopsy, if that's done, may show the evidence of chronic renal disease. Sarcoid is another thing that's seen in youngsters, more often thought to be in older people, however, it can be seen in children. In children aged 8 to 15, it's more commonly presenting as that of an adult with lung involvement. However, in kids 5 years or younger, what you typically would see would be either skin, joint, or eye disease with a lack of pulmonary involvement. So these are things to keep in mind when you're seeing patients. Testing that's done for this often includes the 2 ACE and lysozyme blood tests. However, in children, please note that ACE is often elevated, so you may see that in a normal patient who doesn't have sarcoid. Lysozyme may be the test that points to the disease more frequently. Imaging done can include chest x-rays and spiral CTs of the chest to look for hilar adenopathy, and the gallium scan can sometimes point to hot nodes throughout the body. Biopsy is the definitive way to diagnose the disease. And oftentimes in a child with ANA negative uveitis, this can be something to consider as well, the sarcoid, as normally sarcoid patients are ANA negative. It presents typically as a granulomatous uveitis with large keratotic precipitates on the back of the cornea. In age 5 and under, it's actually the majority of presentation, the anterior form, a little less than half in older children. Other presentations that you can see may be the intermediate, posterior, or panuveitis forms of the disease with retinal vasculitis, chororetinal granulomas, or even eyelid and conjunctiva involvement. So it may not just involve uveitis, but other parts of the eye that are involved. Here's a picture of some inflamed veins in the part of the retina. Blau syndrome is not very commonly seen either, but is something to keep in mind, the so-called familial juvenile systemic granulomatosis. It's an inherited disorder, so a family history is very important. May help distinguish it from previously mentioned sarcoid. And the classic triad of this is a polyarthritis rash and an anterior granulomatous uveitis. Herpetic uveitis is something that needs to be kept in mind, particularly when it's a unilateral presentation. Usually the curatic precipitates are variously sized, but oftentimes you will see the classic stigmata of herpetic disease, transillumination defects in the iris, intracranial pressure that's elevated, and decreased corneal sensation can be present. Corneal changes as well as retinitis may also be present. Infectious anterior uveitis is a problem more oftentimes seen in developing countries outside of the United States, and these are some various problems that can be seen. However, these can also be seen rarely in the United States, so they can't be completely discounted. And of course, malignancy, not commonly seen, but always something in the back of the mind when something doesn't respond quite the same to the types of treatment that you typically get. If a disease is stubborn, it may be something that needs to be thought of. In a study done in 1996 of children who had ocular involvement of their leukemia, it was found that 2/3 of them had anterior uveitis. The other 30 or so percent had posterior panuveitis. And oftentimes the disease presents with anterior chamber cells, hypopyon, and iris involvement, and relapsed about 1 to 6 months or 1 to 6 years after they were initially diagnosed. So moving along to the next types of uveitis, less common in children, intermediate uveitis. The most common type of intermediate uveitis seen is that of pars planitis. Over half of the intermediate uveitis seen is actually of this etiology, and this actually represents about 1/5 of all pediatric cases seen. Oftentimes HLA-DR15 positive, and of course some other diagnoses to keep in mind are sarcoid, MS, and the Lyme disease. In children, it typically onsets about age 9, mostly in both eyes and more commonly seen in males. Symptoms that people will complain of are blurring and floaters, and the findings that you would see on exam would be dense vitreous cells, snowballs in the inferior part of the vitreous chamber with or without the involvement of retinal vasculitis, and other complications, cataract, epiretinal membrane, macular edema. And oftentimes this syndrome actually masquerades as anterior uveitis with dense posterior synechiae that don't allow you to see in the posterior chamber. Posterior uveitis is more commonly seen with infectious cases. Toxoplasmosis is the most common in about 1/3 of all cases. Another 1/4 of the cases are other infections seen. It can be a congenital or acquired disease, and it can develop as anterior panuveitis or posterior uveitis. Some other diagnoses to consider when you see posterior uveitis would be the idiopathic version or sarcoid retinal vasculitis, the so-called white dot syndromes, and VKH. Toxoplasmosis is caused by a parasite found in cats. It can be found in their cat litter and contaminated soil and meats. It can be transmitted by the mother during an active infection. Oftentimes they're asymptomatic during these infections as well, and also by transfusions. And again, this is more common in developing countries. The classic triad of congenital toxoplasmosis is that of choroidal retinitis, hydrocephalus, and intracranial calcification seen in the young infant. However, they can also present with fever, lymphadenopathy, eosinophilia, rash, and neurologic changes. So those are things to pay attention for when you're seeing these patients. Oftentimes when the disease is diagnosed, it's inactive or asymptomatic with scars in the peripheral retina. But keep in mind that many times later in life, these can become active. So as I said, the inactive lesions are the most common presentation, a black-white chororetinal scar seen often in the periphery of the retina, often multifocal, normally not causing symptoms, but if they do involve the center part of the vision, they can become very symptomatic or blinding. And typically when the disease is active, you see this so-called headlight in the fog lesion seen here, an active bright lesion seen through the dense cellular reaction, a necrotizing retinitis with or without the presence of these vitreous cells. And if you do an angiogram, you'll see it light up there. About 7 out of 10 of these children seen in a study in Spain were inactive. However, about 30% of them had active disease. And like I said, they can present with these other findings here. Most often the symptoms that come up are actually misalignment of the eyes and decreased vision. It's often made by clinical diagnosis, but can be done by blood studies as well to help augment this. And actually, fluid from the eye itself can be studied for the presence of DNA by PCR, and if neurologic complications are suspected, a lumbar puncture can be done looking for the same. And the last thing I wanted to talk about was toxocariasis, another parasite, the worms found in dogs and cats. More often found in dogs are the ones that affect humans. And the ova can be shed in the animal feces, contaminate the soil, oftentimes in the playgrounds that we send our children to. And this gets ingested in through the intestine, through the bloodstream, going to the target organs. May not be the eye, may be the liver, heart, or the central nervous system, but can affect the eye. Often presenting here with the granuloma, perhaps with a large tractional band, seeing from the central to the peripheral retina. Most often a granulomatous type of presentation with retinal detachment oftentimes seen. And some of the blood labs seen done may show eosinophilia or elevated toxocara IgG in the serum or in the aqueous. So to sum up the steps that you would take to try to figure out what types of uveitis are seen in the children, the three here, knowing what type of uveitis is seen, how it appears, and of course a detailed history and review of system, and followed up by a targeted group of testing to see what type of uveitis it is. Thank you very much.